Hi, everyone. Good afternoon. Another Thursday edition of Newton-Wellesley Medical Group Lunch and Learn. We are delighted to have Dr. Abe Mohapatra here to talk to us and teach us about carotid stenosis. Next slide, Abe, please. So just teasing our upcoming Lunch and Learns, we have a great talk next week around back pain and behavioral medicine. And then the following week, we have Dr. Saini going to be joining us, and she is a new urogynecologist on our staff. So I'm sure that's one of the topics she'll be talking about. Just folks, just to remind you that the Newton-Wellesley Medical Group Lunch and Learns are all archived up on YouTube as well as on our intranet. And the link is right there to log on to these, and they all qualify for a half hour of category 2 credits or self-learning credits. Next slide, please. So just to, as we move into the summertime and everyone's out there, this family's out there hiking, and we get twisted ankles and bum knees and sore backs and hurt necks and falls off bicycles. Instead of waiting at the emergency room, you come on into our orthopedic walk-in center. We're open 7 days a week, 8 a.m. to 8 p.m. during the week, and 8 a.m. to 1 p.m. on Saturday and Sunday. X-rays, braces, orthopedic surgeons and orthopedic PAs are waiting to help you there. And it is an office copay, not an ER copay, so please let your patients know, and family and friends. Next slide. And I just wanted to just highlight, we have our 5 wellness programs ongoing that I talk about each week, our weekly virtual meditation classes and our virtual yoga class. We have our online coaching and physical training. You can contact Daniel Destin for that, as well as our Peloton 1-year free membership. These programs are all from the grant from last year, and they are starting to wind down. So if you haven't taken advantage of them, please do so. Don't hesitate. Also, Kathleen Servan has come on to help us with our wellness programs, and her email is on this slide. Next slide. Wanted to spend a second just talking about physician care concierge, because this one is winding down at the end of September. If you don't sign up for your 1-year membership, it'll be gone. And this is a great place as a resource for anything in life that you need advice on how to get people to do things for you, or gifts or anything else. You can enroll today by going to community.circles.com, and it'll ask you for the welcome code. All you need to do is type in NWH. Next slide. Just real quick about the program, we've already had 122 registered users, 63 physicians. They're quoted to have saved 4 hours per request of their life. So just logging on has saved people 4 hours each time they ask for something. And of course, the NPS score is over 100. Next slide. And people are asking, well, what would I need this for? These are the kinds of questions that they've been receiving over at Circles. Holiday gifts for a team, surprise gifts for parents, flowers, gift baskets, in-home tutoring, Mother's Day massage, grocery delivery, pet walking, lighthouse tour, home storage options. I've personally used them for some home repairs and some light home repairs that needed to be done. Next slide. And then the research, you can see flowers are the biggest one, but other gifts and contractors and other research is out there, snow removal, hotel choices, tours, movers, etc. This is a free service for you guys if you sign on up and just use the NWH welcome code, and it's a great service. So I would encourage you to do so. Next slide. And I'll hand it over to Abe. Abe, thanks so much Abe. This is the second time back in our hot seat here, and we appreciate you coming back, talking to us and teaching us about carotid stenosis. All yours.
Yeah, thank you, John. Everyone can hear me okay and see the slides okay. I have met with this group before, and I appreciate being invited back. So I guess the last one went okay. I'd like to talk today about carotid stenosis, and I know I've at least electronically interacted with many of you before, but I'm Abe Mohapatra. I'm a relatively new vascular surgeon here at Newton-Wellesley. I started last August, and I've been here since last August. A little bit about our practice. Me and Leslie sort of are running our own practice here at Newton-Wellesley. We're seeing basically the full spectrum of anything vascular that you can think of. Arterial and venous disease. We offer both open surgical and endovascular treatments, and a lot of hybrid procedures that combine both. And we are vascular surgeons are actually pretty proud of this. We're one of the few specialties that sort of does our own surveillance and medical management of these problems as well. And so there are patients that I continue to see in my clinic that I haven't operated on and may never operate on, but I'm happy to sort of manage their vascular problems in the meantime. We do have a vascular lab in-house, and so we can often get testing and an office visit done on the same day, which is very convenient, especially for elderly patients or people with transportation issues. And I am 80% at Newton-Wellesley and 20% at Mass General. And so we offer a good sort of collaborative care model for patients who have more complex problems, where I can actually continue their care on my service over at Mass General as well. And so I think that works well for a lot of patients when they become too sick or their problem becomes so complex that they have to go downtown. This is sort of a summary of all of the things that we offer, or at least the most common things we offer. Aneurysms, lower extremity work, and carotids tend to be the most common arterial services that we provide. On the venous side, we see a lot of patients for varicose veins and leg swelling. Saphenous vein ablations are fairly common for us. We also see patients for phlebectomy and sclerotherapy for their varicose veins. We also offer cosmetic sclerotherapy. And in some patients with deep venous disease, we offer venous stenting as well. Today, what I'm going to talk about is carotid disease. I'll start by talking about just a little bit of background, but really I want to focus on how carotid disease is diagnosed and the ways that we manage them today, and sort of what's new in the world of carotids. Just to start from the basics, this is the perfusion to the brain, and the most important thing on this diagram are the internal carotid arteries and the vertebral arteries, which are the 4 arteries that supply blood to the brain. And up in the brain is the circle of Willis, which connects all of these vessels together. And when the anatomy is normal, which it is in most people, the circle of Willis provides this rich collateral network so that even if 1 or 2 of these vessels goes down, the brain still gets enough blood flow. So carotid stenosis is just a term that refers to buildup of atherosclerotic plaque in the carotid arteries. Most commonly, it happens at the carotid bifurcation, the carotid bulb, and extends into the proximal internal and the external carotid arteries for about 1 centimeter or 2, but it's pretty localized to this bifurcation. The lesions do reduce flow through the internal carotid artery, but that's typically not the problem. The typical problem is that these plaques can be a source for embolization up to the brain. Risk factors for these plaques are your typical atherosclerotic risk factors that we're all familiar with. Smoking is the biggest one. Patients with hypertension, hyperlipidemia, diabetes, especially if these are uncontrolled. And patients can sometimes have a family history or genetic factors that play a role. Like I was sort of saying before, what we worry about most with these plaques is that they can rupture. And when they rupture, either a piece of the plaque or thrombus that develops on top of the plaque can embolize downstream into the brain. And when that causes a permanent ischemic injury to part of the brain, that's how you get a stroke. And you can also get a transient ischemic attack, or TIA, and this is when you have a temporary occlusion of a vessel, but then the body's natural lytic mechanisms can break down this embolus, and the symptoms can resolve. And typically that happens within a 24-hour period of time. The most classic TIA that we talk about is what's called amaurosis fugax, which is transient vision loss, monocular vision loss in the ipsilateral eye to the carotid in question. And it results from occlusion of the ophthalmic artery on the way to the brain. We don't necessarily know which plaques are going to rupture. What we do know is that when plaques are bigger, they are at higher risk. We know when they're softer, meaning they have more lipids and less calcium, they tend to be at higher risk. And certain features of plaques like ulceration or intraplaque hemorrhage can be a sign of impending severe problems. But the most important thing is that plaque size is correlated with the stroke risk, and our best measure of plaque size is the degree of stenosis within the artery. To talk about clinical presentation, we sort of broadly define these patients in 2 categories, symptomatic or asymptomatic. Symptomatic are those patients with strokes or TIAs that I was just talking about. Rarely, it doesn't happen often, but sometimes patients can have global hypoperfusion to the brain if there is too much carotid and vertebral disease, but that's a less common problem we face. Asymptomatic patients are more often incidentally found on workup for some other problem. For example, they had a CT angiogram of the neck for syncope, looking for carotid disease, which ends up not being related at all to their underlying issue that they got admitted for, but we now found it, and now we sort of have to keep an eye on the carotid disease. Carotid Breweries are also another way that these are discovered, and many of you have referred patients to us having found a carotid brewery and done a carotid duplex. And carotid breweries are actually, they're not super sensitive, but they are fairly specific for carotid disease. And so if you do hear a carotid brewery, there's a decent chance that there is some underlying carotid plaque that you'll find on the duplex. There is really no role for routine screening of completely asymptomatic patients. Basically, all of the societal guidelines and the USPS Preventive Services Task Force have said that there's no role for routine screening in patients where you have no suspicion of carotid disease. Once we sort of start to look for carotid disease, our best test to look for this is duplex ultrasound. And ultrasound is really good at detecting the presence of carotid stenosis, and it also helps us to calculate the degree of stenosis indirectly by looking at the flow velocity. You can see in this image on the right, you can see the carotid vessels are labeled, and you can see that dark shadowed plaque in the origin of the internal carotid artery. But it's hard to sort of estimate from that what percentage stenosis it is. And so what we look at instead is actually the flow velocities through a stenotic area of the carotid, and we indirectly from that calculate a degree of stenosis. And so these are the criteria that we use in our vascular lab, and every lab can be a little bit different, and they're validated against other studies like CTs or conventional angiography. And so these are the velocity criteria we use and to report the percent stenosis that you see on the report. The first thing that tends to go up is the peak systolic velocity, but then the way to really distinguish high grade from critical stenosis is with the undiastolic velocity, which is late to increase. So I know many of you order carotid duplex studies, and this is the order that you're looking for in EPIC. I took a little screenshot of it. It's just called ultrasound carotid duplex complete bilateral. Unless you have a good reason to, I would always just order a bilateral carotid study. When you open that, it pops up with this order screen, and you'll note that there's a single carotid duplex order that is used for every MGB site. And so every option, including Newton-Wellesley Hospital main campus, is on this single order. And you just have, really in addition to that, you just have to specify when you want it and what the indication is. Beyond carotid duplex, probably the most common study that we use is a CT angiogram of the neck. CT and MRA do identify stenosis. It's really hard to grade severity of lesions in carotid arteries on these studies. And the reason for that is because the calcium causes a lot of artifact, and you often end up overestimating the degree of stenosis on these axial studies. They do sometimes show plaque morphology. In particular, you can see things like plaque ulceration really well on a CT angiogram. But the most important reason that we use these studies is because it tells us exactly what the anatomy is. It shows us if it's a really long lesion, if it's surgically inaccessible because the bifurcation is too high or too low in the neck. So this is more useful for us as an operative planning study because then we can sort of know what operation we can offer. The other nice thing about CT and MR is that you can just run the scanner up through the head, and you can also image the brain to look for evidence of either an acute stroke or intracranial arterial lesions. This is sort of a representative image of what you might see on a CT angiogram. On the left, you can see a sagittal cut that shows the carotid bifurcation. You can see how the calcium is very bright in the artery, and so it's very difficult to tell how stenotic that is. And then on the right, you have a 3D reconstruction of a similar plaque. And MRA shows you similar images after they've sort of been reconstructed for you. The test that we used to use all the time, we don't do that often anymore, is a conventional diagnostic angiogram. This is an invasive study that typically involves a groin access into an artery and positioning a catheter into the common carotid artery to take images that look like this. It's a really good study in terms of the images it provides, but it is invasive and you have to manipulate the carotid vessels. And so there is a stroke risk involved in just taking these pictures. And so this used to be the gold standard, but now that ultrasound and CT and MRI have gotten so much better, we really almost never use a conventional angiogram for diagnosis. So talking about management, carotid endarterectomy is the one that really has been around the longest in terms of surgical procedures. Carotid stenting is newer, and there are some newer developments in carotid stenting as well. And then I'll talk about medical management of these patients, which should be done in everybody, regardless of whether we revascularize them or not. So carotid endarterectomy has been around since the 50s or 60s. It involves a longitudinal neck incision over the carotid bifurcation. We expose the common internal and external carotid arteries. We clamp the artery proximally and distally, and we are creating some ischemia to the brain by doing this. This is almost always well tolerated without any problems, but in some situations we do place a shunt going from the common to the internal carotid artery during the endarterectomy. Typically in the operating room, we use EEG monitoring to help us decide whether we need to do that. Once we open the artery, we remove the plaque and then we sew it shut again. We often put a patch on the artery to avoid narrowing it when we're closing it. And this is a picture of a kind of plaque that you might see in the bottom right. So you can see the plaque that was sitting inside a carotid bifurcation. This is a really nice operation. It does really decrease the long-term stroke risk for patients. This is especially true when they present to us in a symptomatic fashion, and it's especially true with higher grade stenoses. The risk reduction in stroke is very, very high. And I won't go through all of the trials. There are a million of them. But this works really well in patients who especially have high grade symptomatic stenosis. It's also a very durable operation. It's estimated that in your lifetime, if you have a carotid endarterectomy, there's about a 5% chance that anything will ever need to be done on that side again, which is better than most things in vascular surgery. And it's also generally well tolerated by most patients. There are some risks, but those risks are not inordinately high. One of those risks is perioperative coronary issues. Many patients who have carotid disease tend to also have coronary disease because they have the same risk factors. And so we do risk stratify these patients from a cardiac standpoint before we proceed with surgery. But the thing we worry about most is the risk of perioperative stroke. We are, of course, manipulating this plaque that we think is unstable enough to justify this operation. And so there is some stroke risk associated with the operation itself. Patients who present asymptomatic, that risk is typically 3% or less. And in experienced hands, it's more like 1 to 2%. In patients who presented with a TIA, that risk is a little bit higher. And in patients who presented with a stroke, that risk is even higher than that. And if you are doing an endarterectomy for an acute stroke to avoid a subsequent stroke, the risk can be actually much higher, but may or may not still be worth it depending on sort of the context. And of course, with any procedure, there is a risk of death, and typically that risk of mortality comes from the above two things. Carotid stenting is really the only other revascularization option that we have. And historically, this was generally done through an access in the groin. And we would work our way up and place a wire across the internal carotid artery lesion. We deploy an embolic protection device, which is a filter like you see in that image on the right, and that's supposed to capture any debris that occur while we're intervening. Then you deploy a stent across the lesion and you balloon it open. Important to sort of note that you're not actually physically removing the plaque here, you're just sort of pushing it to the side, and the stent is acting kind of like a retaining wall to keep any of that from embolizing. And then you're sort of done. The newest thing in the carotid world is what's called transcarotid artery revascularization. This is shortened to TCAR. And this does a couple of things differently from transfemoral stenting to reduce the stroke risk of carotid stenting. The first is that it, instead of involving a percutaneous access in the groin, involves an incision on the neck to expose the proximal common carotid artery, proximal to the lesion that you're stenting. And you access the common carotid artery directly with a needle and put this system into place into the common carotid artery. The second thing you do is you access one of the femoral veins and you create a connection between the carotid artery and the femoral vein. And what this does is it temporarily shunts blood backward through that carotid artery into the venous system. And this is a technique called flow reversal, which is meant to capture any embolic debris that would have gone up into the brain will come back into the system, pass through a filter, and even anything that goes through the filter is just going to go into the vein and end up lodged in the lung somewhere, which is much worse or much better than having a stroke from embolic debris. And so TCAR has become increasingly popular in recent years because it has shown some better stroke rates compared to transfemoral stenting. So carotid stenting really is best for patients in two specific situations. The first is when they have a medical contraindication to carotid endarterectomy. So typically what this means is they have severe cardiopulmonary disease and they're not going to do well with general anesthesia. It's also better in patients who have anatomic reasons why they can't get a good carotid endarterectomy. More often than not, this is because they have a high carotid bifurcation that's very difficult to access because it's behind the jaw. It can also be a very low lesion that's behind the clavicle. They also can have anatomic contraindications if they have some reason why they have scar tissue around the carotid artery. So if they've had a prior carotid endarterectomy or any other prior neck surgery in that vicinity, or if they've had radiation to the neck, then it becomes a much more tedious dissection around the carotid, and there's an increased risk of cranial nerve injury is the biggest problem. And so in those patients, we tend to try to avoid doing carotid surgery when we are worried about scar tissue around the carotid. On the other hand, the main problem with carotid stenting is that it actually gives you a higher stroke risk than carotid endarterectomy. And there are a lot of studies that have sort of shown this, and there are some patients that do okay with stenting. There are some patients who don't, and we've really struggled to have good data to ferret that out. And part of the reason for that is because technology is getting better all the time. But one thing we do know is that TCAR seems to be better than a standard transfemoral carotid stent. And so in patients who are amenable to that and are not good candidates for carotid endarterectomy, that tends to be these days our go-to. But in general, we worry about the stroke risk with carotid stenting. And the other thing that's kind of ironic and counterintuitive is that as patients get older, the stroke risk actually gets higher. You would think that the minimally invasive procedure would be better in somebody who's 90 years old, but in fact, patients who are older often do better with a carotid endarterectomy because the stroke risk doesn't really go up with age with endarterectomy, whereas it does with stenting. And so as a general rule, and when we see a patient with carotid disease and we need to revascularize them, we are thinking endarterectomy rather than stenting, unless we have a good reason to think otherwise. Medical management, you guys have often done by the time they see me in the office, and I'm very appreciative of that. But just to mention sort of the important things, anti-platelet agents and statins are probably the two most important things. Controlling their blood pressure, controlling their blood sugar, also important, getting them to quit smoking, trying to improve their lifestyle in terms of diet and exercise. All of these things will reduce the risk that somebody will have carotid disease that progresses to a point where they need revascularization, and it will reduce the risk of needing a re-intervention if they have an operation. It's also important to note that medical management has improved over time. So things like statins and Plavix really didn't exist back in the 90s when the early trials were done. So everybody's stroke rate these days is lower than it used to be when these trials were done, whether or not they have an operation. But the other sort of flip side to this is that over time, we have become more conservative with who we offer carotid revascularization to, especially among asymptomatic patients, because it's not entirely clear whether that risk benefit is still the same as it used to be. These guidelines are about 10 years old now, but these are the most recent Society for Vascular Surgery guidelines on managing carotid disease. And it sort of summarizes what we've talked about before. But what I'll sort of highlight is that what they recommend is symptomatic patients with at least a 50% stenosis, or asymptomatic patients with at least a 60% stenosis and a life expectancy of at least 3 years. They recommend carotid revascularization. And we talked about some of the reasons why you might think endarterectomy or stenting. I'll also note that they did not recommend at the time stenting any asymptomatic patients, except if you were doing a clinical trial. So just as a quick summary, carotid stenosis is a common cause of embolic stroke. We typically use a cutoff of 50% for a symptomatic lesion, or at least 60%. And these days, we really push that to 70, sometimes 80% if they're asymptomatic. All patients should have optimal medical therapy, and in my mind, that includes at the very least an antiplatelet and a statin, and controlling their other cardiovascular comorbidities. And if we decide revascularization is indicated, we tend to think carotid endarterectomy, unless they have a medical or an anatomic risk for endarterectomy, in which case we think stenting. So those are all the slides that I prepared. I'm happy to take any questions, and whether for carotids or otherwise, please feel free to reach out to us whenever. Leslie and I are both happy to answer any questions you might have. Happy to sort of run patients by you, whatever you're interested in. I do see one question in the chat.
Yeah, can you read it, Abe? The question is, does the same medical treatment apply on aortic artery calcifications as well, would you say?
Yeah, in general, yes. I think in my mind, anybody who has sort of calcified plaque anywhere has atherosclerosis. And so anytime I see any of those patients in my office, unless they have a contraindication, I make sure they're taking a baby aspirin, and I make sure that they're on a statin.
Can I ask about, so you said the screening is not recommended, which I think all of us primary care docs know. What about under certain circumstances, and I'll just lay out two that frequently happen. One is in a patient who has known coronary artery disease, should we be screening their carotids, number one? And number two, which is something we're becoming more and more familiar with, is the patient who has atherosclerosis either on a calcium scan or some other scan. Should we be looking at their carotids if they have no symptoms?
Yeah, the guidelines really say no. There are probably some patients that are at higher risk than others. I guess what I would say is in patients like that, I would listen for a carotid Brewery. And if you don't hear one, I don't know that there is necessarily a lot of upside, and it's probably not a very high value test to get a carotid duplex in those patients.
And in your estimation, to hear that Brewery, how large does the stenosis usually turn out to be? Greater than 50, or is it hard to say?
You know, it's hard to say because a lot of times you hear a Brewery and there is in fact a stenosis, but it's just in the external carotid and it's completely meaningless. So it can totally vary.
Yeah. And you leave those alone, the external carotid stenoses?
Yeah, so even when we do a carotid endarterectomy, we don't even try very hard to endarterectomize the external carotid.
Dr. Finn has a question about the indications for antiplatelet treatment. I guess you're saying anyone with symptomatic disease, correct?
Yeah, really anybody with evidence of atherosclerotic disease. The latest AHA guidelines have generally said that patients benefit from aspirin if they have, quote, atherosclerotic cardiovascular disease. And so in my mind, that's a very large umbrella term, but it includes any of these occlusive disease any of these arterial occlusive phenomena. They are the same atherosclerotic plaques that you see in the coronary arteries. And so I think they have been very general with their societal recommendations, and that's sort of the recommendation that we follow. And so anybody I see with any sort of atherosclerotic disease anywhere, I put on a baby aspirin.
Great. And then I guess I'll take advantage of the last 3 minutes and ask you this question that vexes us a lot, which is the patient who comes in with perhaps a known TIA syndrome. How would you as a vascular surgeon go ahead and work up that situation? Classically, we do the MRI and the carotid ultrasound. What do you typically look for or would be thinking about?
Yeah, the carotid duplex is the big thing. I think if they haven't had any brain imaging to show that this was really a TIA and not a stroke, I think that's important to know. It doesn't necessarily change the management. The other thing that I will say, which is a little bit of a nuance, is when we define symptomatic, we are talking about symptoms that have occurred in the last 6 months. So if somebody says, I had a stroke 20 years ago, never bothered me since, all of my symptoms went away, they are technically still in the asymptomatic category at this point.
Last question is, and this comes up a lot also, should we even be putting the stethoscope on people's necks?
It's a fair question. I think there are some high-grade asymptomatic stenoses that are identified with a good physical exam, and I don't think that there is anything wrong with that. If the question is, are we worried about manipulating that carotid plaque to the point where we give them a stroke, I think that is pretty unlikely.
No, I think the question is more about, are we doing, are we looking for something we shouldn't be looking for, leading to more harm than good by finding it?
I don't think so. I mean, I think if you listen for a Brewery and you hear one and you get a carotid duplex and it's negative, it puts you at ease. If you listen for a Brewery and you hear one and you get a duplex and it shows stenosis, then it's something you can keep an eye on. And as long as we are appropriately conservative with who we offer revascularization to, I think it's very reasonable to know that there is carotid disease and to make sure that they're on appropriate medical therapy for it. And I would say the same thing about, for example, PAD and saying, well, there are no pulses in the feet, just because even if they don't have claudication or rest pain or tissue loss, they still would benefit from medical therapy.
Excellent. Well, thanks, Abe. And Dr. Mohapatra and Leslie are around. I know they're very accessible from my own personal experience. So please give them a call with any vascular, arterial, or vascular issues. They'd be happy to help. And thanks. Everyone have a really nice weekend. It's supposed to be really nice outside. Get some vitamin D and get out there. And we'll see you next week to hear about back pain and psychology. Bye. Thanks, Abe.